My name is Stephanie Goslin, and I'm the National Programs Director here at Ovarian Cancer, and I'm excited to be your host for this evening's session. I'm also wanting to introduce you now to our speaker for this evening, Erin Francis. Erin completed a Bachelor of Science in Pharmacy at Dalhousie University in 2012, followed by a pharmacy residency at Ottawa Hospital in 2013. In 2019, she completed a Master of Science in Epidemiology at the University of London. And throughout her career, she has been working with patients living with and receiving treatment for ovarian cancer. Currently, she is a pharmacist at Extend Pharmacy in Ottawa, where she provides specialized care and education to patients receiving oral anti-cancer treatment. So thank you, Erin, for taking the time to be with us tonight. And I'm going to now turn it over to you.
Perfect. Here. All right, is that coming across okay?
Yep, perfect.
All right, well, thank you so much for having me. It's great. It's great to speak to this group again. So I'm going to talk tonight about getting to know your oncology pharmacist. So as was mentioned, I have a background in, I've worked in hospital, so on a oncology unit in a hospital. I've also worked in an outpatient chemotherapy unit within the Ottawa Hospital, and then now currently work in a very unique practice. We are a community pharmacy, but we uniquely provide care to patients receiving treatment just for cancer. So we deal with all oral treatments for cancer, patients who are being treated on an outpatient basis. So I've kind of seen a lot of different sides of the oncology pharmacy world, we'll say. So we'll talk a little bit about that today. So a little bit of background. So what is a pharmacist? So a pharmacist is a healthcare professional with specialized education in managing your medications, to sort of simply put what it is that we do. We work closely with doctors and other members of your healthcare team to ensure that your prescriptions are safe and effective. We can work in lots of different places. So hospitals, clinics, community pharmacies, industry, government, research, and I'm probably missing some other places. So there's lots of places that you will find pharmacists in different capacities providing care. The oncology pharmacist specifically is a pharmacist with experience and specialized training in providing care to individuals receiving treatment for cancer. And even within that, there are sort of subspecializations that different pharmacists can work with specific populations or patients receiving treatment for specific types of cancer. So you may have a pharmacist who works with people with hematological malignancies, or you may have a pharmacist who has worked with patients receiving treatment for ovarian cancer. So there's even specializations within that world as well. And essentially what we do is we assess and monitor anti-cancer treatments and their adverse effects. We assess and manage drug interactions between your anti-cancer treatment and other medications that you might be on to treat other medical conditions, such as diabetes or blood pressure, really anything else that you might be taking on a regular basis. We want to make sure that that's safe to be on while you're receiving chemotherapy or anti-cancer treatment. And a pharmacist also acts as a resource for drug information and education for both patients and also for other members of the healthcare team. So pharmacists, receive many questions from doctors, nurses, and other types of healthcare professionals. If they have questions about medications, we'll provide in-services and things like that to educate other people about medication. So what does my pharmacist do, or what does your pharmacist do? So believe it or not, every prescription is reviewed by a pharmacist before it's given to a patient. So specifically when it comes to chemotherapy or anti-cancer treatments, this is something that's, it's reviewed in great detail because of course these are very high risk medications. We want to avoid error at all costs. And so these prescriptions are reviewed very closely. So in my practice, for example, when I worked in the outpatient chemotherapy unit, if a chemotherapy order was entered into our system, by one of the oncologists, then I would review that order to make sure that it was appropriate for the patient. So I would review their medical chart, read about their visit that they had with the doctor, look at the indication, the dose, the frequency, the route or the way the medication was going to be given, just to make sure that all of those things are correct before any medication actually reaches the patient. And sometimes, of course, everybody's human, and errors do happen. And sometimes those are technical errors. Sometimes those are, the choice of a regimen maybe not, for a new disease that it's not been used often. And so we're sort of reviewing the evidence to see how that can be done. And so we're always that double check or that safety check to make sure that those things are caught and worked out before any medication gets to the patient. We also assess and suggest management of any potential drug interactions between new prescriptions and existing medications, as I talked a little bit about before. We'll monitor patients to assess how you're tolerating treatment and identify if you're experiencing any side effects. Provide education about medication and how to manage any potential side effects. So typically what happens, or at least in my experience and in my practice, when a patient is starting a new treatment or a new type of chemotherapy or a new type of anti-cancer therapy, a pharmacist would sit down with that patient before they receive treatment and review the medications in detail. And I usually like to ask the patient sort of, what do you know already about this? Because of course the oncologist or the doctor will talk about the treatment. So sometimes patients have, burning questions that are on their mind that they want to talk about before they receive this treatment, or, something they read on the internet, something they heard about their friend that received chemo. Is that going to happen to me? Those are the types of questions that I try to help answer for people and try to ease their stress in any way that I can before they start on a new treatment. And also I provide that type of education to other healthcare providers, because sometimes there's some more rare or unusual side effects that happen with chemo. And sometimes we'll have nurses or doctors asking the pharmacist, my patient experienced this type of rash. Is that normally a side effect of this chemo, or is that possibly something else? So sometimes those little intricacies are things that the pharmacist can help tease out if the patient is experiencing a side effect of medication. Pharmacists also stay up to date on current evidence and guidelines for the use of medications in their practice areas. So if there's a new treatment, for example, for ovarian cancer, making sure to be up to date on what that new treatment is it available? Are patients receiving it? How can they receive it? Those sorts of things, you want to make sure that you're on top of those things. In some situations, pharmacists can assist with drug funding or navigating drug coverage, and I'm going to talk a little bit about that later in the presentation. So I've used the term drug interaction a few times. And so I just wanted to talk a bit about this, because you might be thinking, or some of you might be thinking, what exactly do you mean when you say the term drug interaction? So sometimes the way that a drug works in your body can be influenced by other medications that you might be taking. So for example, some medications may cause your anti-cancer treatment to be less effective or increase your risk of experiencing a side effect from your chemo or your anti-cancer treatment. Sometimes your anti-cancer treatment may cause other medications that you're taking for, say, your blood pressure or diabetes to be less effective or increase your risk of experiencing side effects from those medications. So a very important part of what I do and what a pharmacist's job is assessing those drug interactions to determine if they are significant. We use the term clinically significant, enough to require making a change to your medications to help avoid any potential complications. Because of course, first and foremost, when you're starting a new treatment, we always want to avoid any potential harms or complications, and we want to make sure we maximize the benefit of your cancer treatment. So an oncology pharmacist specifically has experience managing drug interactions with chemo or with anti-cancer therapy, and helping your doctor or your prescriber possibly if they have to make changes to other medication that you might be taking because it may impact your cancer treatment. So I have a little case here just as an example of what that might look like. So Mr. Zed is a 70-year-old man newly diagnosed with prostate cancer, and he's been given a prescription for enzalutamide, which is an oral treatment for prostate cancer. He has a past medical history of atrial fibrillation and heart failure, and he has a list of current medications. Not important for you to memorize this list, but just to show that some people are on, quite a few medications before they start their cancer treatment. So what happens next is the oncology pharmacist identifies that Mr. Z's new anti-cancer treatment will actually make the medication apixaban that he's taking for stroke prevention, it's possible that it may make it less effective because of a drug interaction. So the pharmacist would reach out to the cardiologist and suggest changing the apixaban to a different drug that is safe to take with his anti-cancer treatment. So that was just a scenario to sort of highlight the type of what I mean when I say drug interaction and managing a drug interaction. So a day in the life of a pharmacist, what does that look like? It sort of depends on where the pharmacist works. So in the hospital, you may know if you've received chemo or treatment at the hospital, or if you've had to be in the hospital maybe because of a surgery or a side effect from your chemo. Pharmacists are often found on the medical wards or sometimes in the pharmacy department itself. We round with the healthcare team to review patients and assess and monitor their medication therapy. As I mentioned, we meet with patients to provide education and counsel them on chemo and assess how they're tolerating medication. So, stopping in to see a patient who I know received chemo last week and asking them, how are you doing? Are you experiencing any nausea? Are you experiencing any diarrhea? And assessing those things and asking them if they've been using any of the medications to treat those things, and if not, educating them and helping them to understand when and how they can use those medications would be a very common part of what we do. We also make evidence-based recommendations to the doctors or to the prescribers for adjustments or changes to medication based on patient-specific factors. And what I mean by that is sometimes when you're going through treatments or chemotherapy, sometimes things can change in terms of organ function. So sometimes kidney function changes, and sometimes kidney function changes, and that means the dose of medication has to be modified to reflect that. So those are the types of things that we would monitor and perhaps alert the prescriber that a change might need to be made while a patient's kidney function is altered from their treatment. In the community, so when I say community, I mean sort of your typical community, or the other term is retail pharmacy. So something like Shoppers or Pharmaprix, Jean Coutu, those sorts of things would be your typical community or retail pharmacy. So as you know, I'm sure you've been to a pharmacy. Pharmacists are usually found within the pharmacy itself. So they're reviewing prescriptions prior to dispensing to patients. They provide education to patients about their medication therapy and assess how they're tolerating treatment. And of course, you can probably see them always answering the phone. They get a lot of phone calls from patients and also other healthcare providers asking questions about their medications and various other things. And so, of course, there's always the joke of how long does it take to put a sticker on a box? And this is just to highlight that what's going on behind that counter is there's a lot more going on than just labeling a prescription. There's a lot of thought that goes into making sure that those prescriptions are safe before they get into a patient's hands. And just to talk a bit about what happens. So what happens when your prescription arrives at a pharmacy? So I thought maybe we'd walk through sort of the life of a prescription. So Mrs. Smith is a 60-year-old woman who's recently completed first-line chemo for ovarian cancer, and she's about to begin maintenance treatment with Lynparza or olaparib, and she was given her first prescription to take to the pharmacist. So what happens now? So the first thing is that the pharmacist will review the prescription, so we'll confirm the correct indication. So the pharmacist will generally ask you a few questions when you drop off a prescription. So to confirm that she does have ovarian cancer, confirm that the schedule, the dose, the administration instructions on the prescription are all correct, and then review the profile for Mrs. Smith to see if she has any allergies or any other current medications that may influence the olaparib to make sure that it's safe for her to take. And then also review Mrs. Smith's other medical conditions to assess if they could be impacted by treatment with olaparib. So if she had any sort of underlying conditions that the side effects of olaparib may make those conditions worse, then that would be something you might include in your counseling or your education to the patient of how they will monitor themselves when they're on treatment. Then the prescription is prepared, and this is more of a technical function. So the medication is scanned, counted, packaged, and labeled. This job is often performed by a pharmacy technician or pharmacy assistant. And then the final product is checked for accuracy to make sure, of course, that's the right drug, the expiry, the lot number, all of those things to make sure that everything is technically filled correctly. This job can be performed by either a pharmacist or a pharmacy technician, depending on where the setting where it's happening. And then, of course, the final step is to dispense the prescription to Mrs. Smith. And with that dispensing to her is providing education to Mrs. Smith about her new medication. So reviewing how to take the medication and any special administration instructions. So for example, if she had to take her medication on an empty stomach, letting Mrs. Smith know about any potential side effects, when they might occur, and how to manage them if they do happen. Any special monitoring requirements, such as blood work. So if she needs to have any blood work, and what will be monitored, and then addressing any questions or concerns that Mrs. Smith might have about her new treatment. And I realize when I say these things, I'm speaking, from my perspective as an oncology pharmacist, reviewing prescriptions for anti-cancer treatment in this much detail is a very normal part of my day-to-day, and this is sort of exactly the flow of my interactions with patients. It depends on what province you live in and how you receive your oral anti-cancer medications, for sure. In some provinces, you'll receive those from a cancer center. And so likely you would interact with an oncology pharmacist in that scenario. But in some provinces, there's a bit of a mix, and you can fill these prescriptions at a general community pharmacy versus the cancer center. So a person may not always have the ability to meet specifically an oncology trained pharmacist, depending on where their care is occurring and what type of treatment they're receiving. So, I mean, I hope at some point in your treatment and in your journey, you do meet a pharmacist and you're able to have this meaningful interaction. But an oncology pharmacist just has that extra experience and expertise to provide this education in a bit more detail, because this is what they see kind of day in and day out is patients receiving cancer treatment, versus a community pharmacist who may only have a handful of patients that fill their prescriptions there receiving cancer treatment. So what does your healthcare team look like? I've said a few times that a pharmacist is a member of your healthcare team. So the healthcare team is a lot of people. And of course, at the center is you, the patient, and everybody is working for you to have, the best possible experience, and that you receive the most benefit from your treatment, and that your quality of life is maintained. And so of course that includes all the different types of doctors that you may meet. So your family doctor, your cancer doctor, the surgeon if you require surgery, of course the nurse, pharmacist, maybe you'll meet a dietitian who will talk to you about dietary modifications or food modifications to help you during your treatment. You might meet a social worker who helps with drug funding, or if you have to receive treatment and need special housing and travel for your treatment, and even a physiotherapist if you're recovering from a procedure and you need help sort of getting back to your baseline level of functioning. These are all people that might be involved in your healthcare team. And just to let you know, we're there. A pharmacist may not always be as visible as some of these other members of the team, but certainly they're there somewhere in the background. Sometimes I say we're like the shoemaker's elves, that they come in and they do things and nobody sees them, but the work does get done. So I think, if you're wondering if there's a pharmacist involved, you can always ask, is there a way to speak to a pharmacist, or can I speak to a pharmacist? And sometimes you might be surprised that they're out there somewhere, and you can ask them your questions. So important for patients to know is, how can my oncology pharmacist help me? So we are your resource and your support for all things medication related. So the way I think that we can help you, or how an oncology pharmacist can help you, is to help you understand more about how and why you take certain medications. And it surprises me sometimes that people don't always clearly understand why they've been prescribed something, and they're a bit shy to ask why. So the pharmacist is the perfect person if you're unsure why you're on a medication, to ask, what is this doing for me? How is this helping me? That's something we can certainly explain to you. We can help you know the signs and symptoms of medication side effects and how to manage them. So if something weird and wonderful happens that isn't the norm for you, you can always ask a pharmacist, do you think that this is because of my cancer treatment? And they can help you navigate that, and help you know if you need to seek medical attention for some of these things. We can help you understand when and how to best use supportive medications to treat those side effects. So for example, anti-nausea medications, anti-diarrhea medications, it's a lot, I know, for patients, or I can appreciate when you're handed a new prescription for a cancer treatment, and then you're also handed 5 other prescriptions for new medications, and somebody's just, rhyming all this information off to you, and then you go home and you think, well, how exactly am I supposed to use these things? When do I use these things? And don't be scared to ask the pharmacist how to use these medications to best treat your side effects, because we're here to help you do that. We can help you know if it's safe to take new medications or natural health products with your anti-cancer treatment. So certainly whenever I do a follow-up with a patient, one of the questions I always ask is, have you started any new medications or been given any new prescriptions since we last spoke? And if the answer is yes, I'll always check to make sure that those new prescriptions are okay with their anti-cancer medication. And especially if you're getting things that are over the counter or from a naturopath that might not be on your medication profile, you can always call and just, double check with a pharmacist to make sure that they're aware that you're on this, and just to make sure that it's safe for you. I get those questions a lot from patients. I'll talk next a bit about drug funding, because I mentioned that's another thing that sometimes pharmacists can help with. This is, it's a big topic. Drug funding is a whole could be a presentation in itself. It's certainly not my expertise, but it's because funding and insurance coverage for anti-cancer medications, it's complex, and it can be different for every drug and different for every patient. In hospitals and cancer centers, for that reason, there's generally someone called a drug access navigator, or a DAN. So you may, depending on where you've received your treatment, interacted with a drug access navigator at some point to help you secure funding for your treatment. And as I mentioned, depending on which province you live, you may receive your anti-cancer medication directly from the cancer center, or it may come from a community pharmacy. And it's important to understand that confirming the coverage, it can take some time. And I know that's very frustrating for patients that, you see the oncologist, they talk to you about a new treatment, and then there's a bit of a lag time to start that treatment sometimes, because the funding and the insurance has to be sorted out. So this often can influence how quickly you can start your treatment, because it may take a few weeks to get all of that sorted out. Anti-cancer medications can be covered in a lot of ways. So we have private insurance. So if you have, something like Manulife, Sun Life, your own private insurance plan can sometimes cover. There's public funding from the provinces, depending on the specific criteria for the medication. There's sometimes compassionate coverage from the drug company itself that produces the medication. Ideally, and I say ideally, drug funding should be in place before you present to a community pharmacy with your prescription, because ideally it's not a good position for you to show up to pick up your prescription and only to find out at that point that there's all this background work that needs to be done to make sure that your medication is covered, and you're not footing the bill for these very expensive medications. So sometimes, depending on where you live, an oncology pharmacist might be involved with your drug coverage. Sometimes the drug access navigator might also be a pharmacist if you live maybe in a smaller center. So this is just to, I guess, touch on this sort of big topic, because I know it's very confusing for patients, and to be quite honest, it can be sometimes very confusing for us too. So it's a big topic, and we try our best to make sure that this is all sorted out for you so that it doesn't cause you extra stress. Drug funding in Canada as a whole, this is just a little diagram to sort of show you what that process looks like. So essentially, a drug company submits an application to Health Canada to have their medication reviewed, to have the evidence reviewed, with the hopes of having that medication, approved for use in Canada. And when they get that notice of compliance or that approval, then this goes on to a body called CADTH, which is the Canadian Association of Drugs and Therapeutic Devices in Health. And so what they do is review the evidence and the clinical trials for these new medications, and then they go on to make a recommendation to the provinces to say yes or no, you should publicly fund this medication for patients in your province. And sometimes in that interim, when that evidence is being reviewed, you'll have a drug company funding the medication, and you'll receive what's called a compassionate supply. And then if the province does agree to fund this medication, then there comes a criteria that patients will receive it publicly from the province. And so this just to show it's a very complex process that kind of gets a drug to the point where it is or is not funded. And pharmacists are involved in this process, and they work at both Health Canada and CADIF. So in different capacities, there's pharmacists along the way here, sort of reviewing that evidence and also giving their recommendation. So cancer treatment is changing a lot, and the amount of oral cancer treatment now is so much more than even 5-10 years ago. So effective oral treatments are becoming more widely used. It gives patients more freedom and independence while receiving their treatment compared to that traditional IV chemo where every 3 weeks you have to be at the cancer center for your appointment. You can't necessarily travel, you have to be around for blood work. This is very different in that you control the treatment at home, and you're responsible for giving yourself your medication. So it also means that you have less interaction with the healthcare team. So before, if there was this every few weeks touch point when you knew you were receiving chemotherapy and you knew you were going to see somebody if you had a problem, now patients are at home and having a little bit more independence in managing those problems. And so I think an access to an oncology pharmacist can help patients, help you feel more confident in managing the treatment and self-monitoring for side effects. And this is, again, a big part of my day-to-day job is, checking in with our patients with of course, COVID right now, it's largely virtual. So calling them at home to check how things are going with their treatment and, seeing if anything new has happened and helping them navigate, do they need to go to the emergency department? Can they take their anti-nausea medication? Those are all things that I can help patients to the best of my ability to understand. So that's all I really had to say. I don't know, Stephanie, if you want me to go through with this portion first or take any questions about the first part of the presentation now.
Thank you, Erin. You know what? Let's go with the questions that we have. So just for everybody's benefit, we did have a few people that submitted questions in advance. So Erin, yeah, why don't you go ahead and answer those? We have one question in the Q&A right now. So please, if you have questions, now's your time. Erin's here and very willing to answer anything you might need asked.
Yeah, so that's perfect. We'll do a little Q&A, and these actually fantastic questions that people sent ahead of time. Really, really good questions. So this first one here, so someone had asked, how does olaparib target the BRCA mutation in ovarian cancer cells? So I don't want to make this too complicated and boring, but essentially olaparib does not target the BRCA mutation itself, but it's found to work better or be more effective in people that have the BRCA mutation. And I'll explain why that is. So our cells are constantly replicating and dividing, and that's not a perfect process. So when the cells divide and they replicate, sometimes DNA gets damaged and it causes a break in the DNA. And PARP is an enzyme. So olaparib is what's called a PARP inhibitor. So this PARP enzyme comes along and essentially it is involved with the process of repairing that break in the DNA so that the cell can go on to survive. So we don't want cancer cells to survive. We want them to die so that the cancer cannot replicate. So by inhibiting this enzyme, this PARP enzyme, it doesn't allow the cell to fix that break in the DNA. And then that single break goes on to be a double break. And the hope is that the cell would die. So in somebody that has functioning BRCA or no mutation in BRCA, the job of BRCA is also to fix breaks in the DNA. So the BRCA could come in and then help, and the cell could survive. But you could see if someone has both a PARP inhibitor like olaparib and also a BRCA mutation, they've lost two ways that the cancer cells can repair the DNA. So the cancer cells go on to die. And that's what you can see in the bottom section of the diagram here. So it's not so much that olaparib is targeting that mutation in the cancer cells, but it's almost working with that mutation to be sort of a second second deficiency in the cell being able to repair itself. And we know now that there are other genes involved with the term is homologous recombination. So we know there are other genes involved with this now. We're learning as we go along. It's not just BRCA, but certainly BRCA is a big one and has been found to, certainly patients that have this mutation, they respond well to olaparib for that reason. So I hope that's sort of somewhat clear. And I borrowed this diagram actually from AstraZeneca, who make olaparib, because I thought it's a nice sort of picture to show the two places where these things work. Another question that was submitted was, are there any vitamins or minerals that help to raise low red blood cells? And that's a good question. And I can see probably where this question is coming from, because we know anemia or decreased hemoglobin is a potential side effect of all PARP inhibitors. So not just olaparib, but niraparib or Zejula as well can cause anemia. But anemia can also be secondary to cancer itself. So you'll maybe sometimes hear the term anemia of chronic disease. So cancer is a disease that can cause hemoglobin to drop. Like chemo, olaparib or PARP inhibitors can impact the bone marrow, and they can cause low white blood cells, low platelets, low hemoglobin. And these counts, we want them to recover from chemo before somebody starts treatment with a PARP inhibitor. So it's thought that the risk of anemia, it might be cumulative with olaparib, which means that it might increase with longer exposure. So the longer you're on the medication, the more likely you are to develop anemia. But often what we see is that it usually occurs in the first 3 months. For some patients, it happens early on, but the risk of being on it long-term is potentially that would occur. Unfortunately, there are no evidence-based supplements or vitamins or minerals that have been shown to raise low red blood cells. But I say this unless you have been diagnosed with a true deficiency. So there are different types of anemia. You can have an iron deficiency anemia, you can have a folate deficiency anemia or folic acid, or you can have a B12 deficiency. Those are just some examples. If you've had blood work and someone has told you that you have a deficiency in one of those, then of course, replacement of those things can help correct your anemia. So that's a kind of a unique situation. But for somebody who is who's on treatment, whether it be chemo or PARP inhibitors, the anemia that's caused by these medications, it's not something that we would typically have a quick fix in terms of a supplement to correct. Usually when someone is symptomatic of a low hemoglobin, which means they might be short of breath, they might be lightheaded, they might have trouble exercising. Some patients say, I find going up the stairs is really difficult now. These are kind of symptoms of low hemoglobin. And typically how those are managed is a dose interruption, which means that we would hold the PARP inhibitor for some time until it recovers. And if it's really symptomatic or very dangerously low, then you may require a blood transfusion. So those are really the only kind of methods we have of truly treating the anemia, unless, as I mentioned, you have been diagnosed with a true deficiency and have another reason for having a low hemoglobin. Next question is, why does my treatment have a fixed duration? This is tricky. So often this is dictated by the funding criteria. So when I talked about the provinces making that decision of whether or not they're going to fund a medication, that is usually, or can be, I shouldn't say usually, but can be accompanied also by a very strict or very clear recommendation of a time frame or how many cycles that treatment can be given. And that is based on the evidence taken from how the medication was given in clinical trials. So an example I have here is that PCODR, and that stands for the Pan-Canadian Oncology Drug Review, which is a subcommittee of CADTH. They make the recommendations specifically for cancer drugs. PCODR recommends the funding of bevacizumab for patients with advanced ovarian cancer in combination with carboplatin and paclitaxel for chemo cycles 2 through 6, and then for up to 12 additional cycles or disease progression. So that is the recommendation of how the provinces will cover this medication. Now, sometimes we don't know if a treatment has any benefit beyond a specific duration, or sometimes there's a risk of treatment harm if you continue beyond a certain duration. So we never want to give somebody a medication if the harm outweighs the benefit. So if, for example, with this recommendation, perhaps it was found that giving longer exposure to bevacizumab didn't make any difference. It didn't change the outcome for the cancer. Then they would go with this recommendation as was done in the clinical trial. So that's generally where those recommendations come from. What are the potential long-term side effects of taking olaparib? So really the three big ones that I would think of is, as we talked about, the risk of anemia or decreased hemoglobin. This may increase with longer exposure. And I say this because that's what was found in some of the trials when patients were followed longer or on olaparib for longer, they tend to experience more anemia. As I'm sure everyone has read, and we'll see a few more questions come after this, about secondary malignancies such as myelodysplastic syndrome or MDS and acute myeloid leukemia or AML are something that came up in the clinical trials, both the SOLO 1 and SOLO 2 trial. But this is a bit special because it did occur, but there were possibly other contributing risk factors for developing these blood cancers, we call them. So these are hematologic or blood cancers. And some of the risk factors are previous radiation, previous platinum-based chemotherapy. So carboplatin is what we call a platinum-based chemo, and certainly the backbone of chemotherapy for ovarian cancer is usually carboplatin and paclitaxel. So the women in these clinical trials, of course, had exposure to chemo prior to receiving olaparib. Some people that developed these secondary cancers had a previous cancer, or they actually had a pre-existing bone marrow dysplasia, so a problem with their bone marrow that may have increased their risk for developing these cancers. So there's a few other factors at play here, not just the treatment with olaparib. And the last one I'll mention is something called pneumonitis, which is an inflammation in the lungs. And this is a rare side effect with olaparib, but it can occur after months to years of treatment. So not necessarily something that would happen right away, but again, a rare side effect. So specifically those secondary cancers, and I think this seems to be something that people are quite interested in. So I have this sort of in quite maybe a bit too much detail, but I hope this answers the question for you. So the SOLO 1 trial, which was the study that looked at maintenance olaparib in women that were newly diagnosed with ovarian cancer, these patients were treated on average for 24.6 months. So they were on olaparib for 24.6 months after they received their upfront chemotherapy. So in this study, they found that AML, which was the acute myeloid leukemia, occurred in 3 out of 260 patients, so 1% in the olaparib group, and no patients in the placebo group. New primary cancers of any kind occurred in 2% of patients in both the olaparib and the placebo group, so the group that received no treatment at all. All of these cases of AML occurred more than 30 days after the end of the treatment with olaparib. In the SOLO 2 trial, this is maintenance therapy in patients with relapsed ovarian cancer. So these patients have what we would use the term more heavily pretreated in that they've had more exposure to chemotherapy. And AML occurred in 2 patients, so 1% of patients, MDS in 1 or 1% of patients, and CML, another type of blood cancer, in 1% of patients in the olaparib group. And AML also occurred in 1 patient and MDS in 3 patients in the placebo group. So as you can see, even the group that had no treatment still had the occurrence of these blood cancers, not just the patients who received olaparib. The risk of secondary cancers during this study and the long-term follow-up was 6 patients, so 3% in the olaparib group and 5% of patients in the placebo group. So this is why monitoring for MDS and AML was one of the conditions of olaparib regulatory approval. There is some research to suggest that patients with a BRCA mutation might have a higher risk of these blood cancers. So it may not potentially be just the olaparib, but the patients who were enrolled in this trial had to have a BRCA mutation. So potentially that plays a part. In SOLO 2, there was a substantially higher incidence in patients with the BRCA mutation who had relapsed cancer when they were followed for 5 years. But all cases had potential contributing factors for the development of MDS and AML, such as having received previous chemo. So these were not patients that just received olaparib and had no other risk factors. So at long-term follow-up for both of these studies, the risk of MDS and AML remains at less than 1.5% at the 5-year follow-up of the solo 1 patients. So as I mentioned, these patients on average were on treatment for 24.6 months, but even after the trial ended, they continued to follow these patients. And at 5 years out from the study, that the incidence of AML and MDS remains at less than 1.5%. And then based on follow-up of 5 years of the solo 2 patients, which were the relapse patients, there were 16 cases of MDS and AML, so 8.2% in patients with olaparib, but also 4 cases or 4% in patients who received placebo. I'm sure there'll be some questions about that at the end, and I can try to tease it out for you, but I guess just the take-home point is that the signal was there that potentially there was an increased risk for these blood cancers with olaparib, but it doesn't seem to be so straightforward that olaparib was, the sole cause and that there wasn't other contributing risk factors. And as you can see, even patients in the placebo arm develop these blood cancers. So it's certainly something that's monitored by Health Canada. And definitely I can appreciate as a patient when you hear the term secondary cancer, when you're being treated for cancer, you would have some questions about that for sure. And I think this is our last question, is there anything you can take to help the hematologic parameters recover from chemotherapy so you can start treatment with a PARP inhibitor? Unfortunately, no. There are medications, and probably why you asked that is you might be familiar with medications such as filgrastim or pegfilgrastim that are sometimes used when patients are on chemo to help their counts recover when they're not recovering on their own between chemotherapy cycles. But those types of medications would not routinely be used for this purpose. And I say this because your bone marrow needs to recover after chemo. And so typically you have time before you start your PARP inhibitor. Somebody doesn't finish chemo and then go right onto their PARP inhibitor the next day or the next week. There is some time, and that's to recover from the chemo. And with olaparib, generally, I know there's a stipulation for one indication that ideally you start within 8 weeks of finishing your chemo. So the hope would be that your bone marrow has recovered and your counts have recovered in that time frame. And we know that myelosuppression or reduced blood counts is also a potential side effect of the PARP inhibitors, and a bit more so with Zejula or niraparib. It can be a little worse for this. So we would want to know that your bone marrow has recovered before we start you on another treatment that could potentially cause these problems. So I don't know that it would do any favors to sort of boost them up quickly, because you may just run into some troubles again when receiving the PARP inhibitor. There's no natural health products, vitamins, or supplements that we recommend to increase white blood cell count. So there's no natural health product that's been shown in clinical trials to correct a low white blood cell count. And yeah, so that's the end of our questions. So I saw the question window sort of popping up while I was answering questions, maybe creating more questions. So I'll just stop sharing my screen here, and then let me get back here. Okay,
Perfect.
There we go.
Thanks,
Yeah,
Erin.
no problem.
Yep, so we do have several more questions in here, so I am going to go ahead and start those. So I have a question from Catherine, and Catherine has been treated for ovarian cancer twice, but she's never spoken to an oncology pharmacist.
Okay.
Is that common for patients to interact, or uncommon, or what can she do maybe to help her speak with a pharmacist?
Yeah, no, it's a really good question. That's why I say it's going to differ depending on where you're treated. Now, if you're treated, I had the luxury of working at a big center in Ottawa, where, yeah, I would say it would be kind of unusual if you didn't meet a pharmacist when you started chemo. But maybe in some smaller centers that maybe have fewer pharmacists, or perhaps their pharmacists don't specifically specialize in oncology, but maybe they also cover, say, medicine or cardiology, and they're kind of bouncing around between places, the access might not be there that every patient would get to have that interaction. It doesn't mean that they didn't review your chemo and take those those safety steps, but unfortunately you didn't have the face-to-face interaction. So it probably does vary a little bit by the size of your center and what the practice is at your center. But in the second part of your question, sorry, was could you ask? Is that what you had said, to speak to one? Is that what you had?
Yes.
Yeah, I mean, I hope so. I don't know where you're being treated, but I hope that you could ask, and certainly you can ask your gynae oncologist maybe if they may work with a pharmacist, or they may have somebody that they could direct your questions to. But I mean, it never hurts to ask. Nobody's going to fault you for asking the question, because it's too bad. I know it's not the luxury we have in every center. Even when I mentioned, physio and dietitians and social workers, I know not every center has the capacity for you to meet all those people, and it doesn't mean they're not in the background doing things for you. It's just they might not be visible to you.
Thanks, Erin. Okay, next question. Is there an alternative to Odanderson SL? When on chemo, because of my allergies, I have to take Odendestron. I'm not sure how to pronounce it, sorry.
Ondansetron. Yeah, I know what you mean.
Ondansetron.
Yeah.
And this medication makes me nauseous. Someone told me there is another anti-nausea drug taken every 72 hours. She's allergic to artificial dyes, which makes her care a little more complicated when it comes to finding any medications. Any information you could share on that?
Ooh, that's a tricky, without knowing the dyes, and honestly, that would probably require a little, those are always the tough questions you get. You have to pull out the product monograph and read every component. Definitely, if ondansetron doesn't work or doesn't agree with you, lots of other options, even in that family of we call them 5-HT3 receptor antagonists. There's granisetron, there's another one called polonosetron. So even in that family, there are other options. I know for some patients I have that get really bad headaches with ondansetron, we can even switch them to another anti-nausea from that family. And if that family doesn't work, we can, we have others. One that you take every 72 hours. I'm not sure specifically. I wonder if that might be one of a different class of anti-nausea medications, or potentially it's given through an IV. I'm not sure, but yeah, for anti-nausea, the world has really changed. Back in the 90s when people received chemo, sometimes they think they even received it with no nausea medications, and now we have just so many options, so many different classes. So if one is not working for you, I always say to patients, we have a starting point, but if this isn't working, then we go from there, because we have a starting point that usually works for everyone, but not everyone fits the mold.
Okay. Awesome, thank you. Another question here is about carboplatin.
Mm-hmm.
So I experienced an anaphylactoid reaction to carbo during my 8th chemo treatment.
Yeah.
When I need further chemo, what else could I get, or what would be the next steps?
Yeah, I mean, I don't want to say too much, because without knowing the specifics of your situation, I don't want to kind of step outside, but definitely
Sure.
the more. So carboplatin is kind of funny in that, as probably everyone who's received paclitaxel knows, the risk with the first 1 or 2 cycles is we're watching you like a hawk for a reaction to the paclitaxel, and the nurses making sure, how are you feeling, how are you doing, slowly ramping up the infusion, and we give you medications to prevent a reaction. And then when that goes well, you carry on, and usually that risk is over. The carboplatin is actually the opposite. And when we see people react to that chemo, it's generally in the later cycles. So after, 6, 7, 8 cycles, kind of like what happened to you, what you're describing. Depending on where you're treated, it doesn't necessarily mean you can't have carboplatin again. Depending on the severity of your reaction. So I know in our center, we have what we call a desensitization protocol. So we have, it's very extensive. It takes a lot longer to administer the carboplatin, but basically giving you kind of tiny increasing amounts until we see you can tolerate it. Sometimes when people react to a chemo, we can change what we call the pre-medications that we give before. So maybe giving some steroids, giving some antihistamines to try to prevent a reaction. So without knowing the specifics of what can happen at your center, maybe they have a desensitization and you could receive it. Sometimes when that happens, we can try cisplatin and the patient does okay. So those are kind of the 2 chemos in the platinum family that we use for ovarian cancer.
Okay.
Yeah,
Thanks, Erin.
I never like it when that when that happens. It's not fun for the patients, and it's not fun for us either.
A couple questions now. I have two left, and they're both in regards to side effects.
Mhm.
So I've got a question here. What are the long-term side effects of niraparib or Zejula?
Yeah, good question. Can I send you an email? Zejula is
Yeah.
kind of I have obviously much more clinical experience with olaparib. Anemia for sure is a biggie with Zejula. It's seemingly more so than with olaparib. I think we see more of that with the Zejula and the drop in like the platelets and these other things. So I don't think that's as much of an issue when you compare the two. In terms of the long-term side effects, I don't know the numbers off the top of my head for the secondary malignancies with Zejula, and with the question someone had specifically, I think, asked about olaparib, so I pulled those two trials. But I can pull out the niraparib trial and see in terms of the secondary malignancies what those numbers look like if it's similar. I suspect it's a class effect because, as I mentioned, these patients have received chemotherapy before, and sometimes there's other risk factors for those malignancies. But yeah, I'm happy to pull that, and then I can send you some numbers to share.
Perfect. That would be great. Thank you, Erin. And everyone on the webinar tonight, I will email those out when I get them from Erin.
Yeah.
So thanks for the.
I should comment too, another difference between the two, olaparib versus niraparib. We don't see increase in blood pressure. We don't monitor that with olaparib the way we do with niraparib. So for those of you that have started treatment with niraparib, you know, probably getting your blood pressure checked every week or so for the first little while. And so that's something that's a bit different with niraparib than olaparib.
That's a perfect lead into the last question here. It's are the effects similar between Zejula and olaparib?
Yeah. I think the big difference is for sure the blood pressure. Like it's not really something that's on your radar as much with olaparib, and a bigger impact on the blood counts. So I think when I poll some of my colleagues, they definitely have more patients that have low counts and maybe have the odd patient that does require a blood transfusion when they're on niraparib versus olaparib. I think that's not as common. And I'm saying this kind of anecdotally in practice, but also if you look at kind of the numbers on the product monographs, it's a bit different. And yeah, I mean, otherwise, I think from a nausea perspective, I think like those sorts of things, I think relatively similar.
Okay.
Yeah.
Great.
Thanks,
Erin.
If you have a second, I mean, I could pull up the monograph, but maybe it's easier if I email you, but I could compare the percentages and show you from between the two.
Yeah, sure. I think if you send them to me, then I can send them out.
Yeah.
That'd be perfect.
Yeah, no problem.
So I don't have any more questions. I don't know if anyone else, if anybody has a question, now's your opportunity. We do have a little bit of time left, but
yeah, I'm happy to take more email questions after the fact. Like that's no problem too.
Okay,
Yeah.
excellent. Well, thank you for offering that up. So everyone on the call tonight, if you do have other questions, you can email those to me.
Yeah.
And we'll get those to Erin and get them back to you. So that's a really nice offer. Thank you, Erin, for doing that.
Especially for that person who told me they haven't met a pharmacist. You can email me.
Perfect.
Yeah.
Thank you.
Okay. Well, I hope this was helpful and really insightful questions. Actually, like I think like really, really great questions.
It was super helpful for me too, even just listening. I sometimes feel that I use the word underdog. I feel like the pharmacist is kind of the underdog of the care team, and yet you can spend so much time and learn so much from them. So thank you again for enlightening us on that. So that is the end of our session for this evening. Again, thank you, Erin, for taking time out of your evening to share your expertise with us and your experience.